Welcome everyone to today's webinar. We will just wait for another couple of minutes for people to join, and then we will start off in another 2 minutes. So kindly hold on. If there are any questions, please put them in the chat box that is available on the right-hand side of your screen. Please enter it over there, and we will answer it at the end of the session. Thank you. Okay. A very warm welcome to all our participants. Thank you so much for joining us today. We welcome you to the third webinar in our series on COVID-19 pandemic, which is brought to you by Reshe Healthcare and Schulke India Private Limited. We would like to thank our support sponsors, Schulke, for this wonderful support they have shown us all throughout this program. Thank you for them. We would like to now welcome all of you for this very important webinar, which we are talking about the special circumstances that one has to face during COVID-19 pandemic, especially in our hospitals. The special situation that we're going to be talking about include a number of areas in the hospital which are high-risk areas like the dialysis, the labor room, the CSSD, and how we need to tackle these when we have patients that are there. So this is what is going to be our challenge for today, and this is what our speaker is going to be highlighting us upon. So without further ado, I would like to welcome our speaker for today, a very good friend of mine and a very well-renowned person in the field of infection control. A big round of applause for our speaker, Dr. Debkishore Gupta, who is the consultant and head of clinical microbiology and infectious disease and infection control at Ruby General Hospital, and is also a visiting consultant at CMRI and BM Birla Hospital in Calcutta. So we would like to welcome you, sir. Thank you so much for being a part of this program. Dr. Debkishore has a number of key highlights during his illustrious career. He has completed his postdoctoral fellowship from molecular microbiology from the University of Central Florida in the US. He has trained in infection control from New York State Department of Health. He's also completed illustrious fellowship in clinical microbiology and infectious diseases in Netherlands. So it's very rare to see microbiologists with ID training in India. So he's one of the few people who are so well knowledgeable about this field. He's also completed postgraduate diploma in ID physicians. He's the founder secretary of the HISI chapter for West Bengal. He has definitely been a speaker both nationally and internationally, and he has a number of publications about national journals, 6 publications, and international journals, about 18 publications. So without further ado, I would like to welcome Dr. Debkishore Gupta. Thank you so much, sir. And please, we would like you to take ahead this topic. I will stop sharing my screen right now. Thank you. Welcome, sir.
Thank you, Dr. Shashank, for this kind introduction. And at the outset, I must thank Reshe Healthcare, also Schulke, for offering this opportunity. This is much needed, especially in this COVID situation. And as we all know, this is an evolving field. So every day we need to update our knowledge. And these kind of webinars are actually very, very helpful. And if some speakers have spent some time over updating his knowledge, I think that can be readily distributed or disseminated among others, which is the best thing, because these days we are flooded with so many information. So filtering and understanding the real information sometimes becomes difficult. Not only difficult, it also becomes time taking. So these kind of seminars and webinars are actually very, very useful. So I'll straight away go into my topic. Is it visible?
Yes, sir. Your screen is visible. Okay. You can please start, sir.
So I'll be discussing infection prevention control protocols in certain special circumstances during this COVID-19 pandemic. So to begin with, the dialysis unit. Why dialysis unit so special? Because patients, they cannot avoid dialysis because of COVID-19. It's not like certain elective procedures, so they must come and spend time in hospital care. And the dialysis patients are also quite unique, because the chronic kidney disease stage 5 patients on dialysis, mostly on maintenance hemodialysis or continuous ambulatory peritoneal dialysis, are vulnerable because primarily of their existing comorbidities. Many of them are diabetic, hypertensive, or certain other conditions, and they're having repeated unavoidable exposure to hospital environment, and you just cannot stop it. And finally, the immunocompromised condition. The result is the asymptomatic and pre-symptomatic patients are very difficult to unmask. So unless and until you have a very high index of suspicion, you have a very strict, stringent, screening mechanism, you're going to miss. And I believe any point of time you do a survey in the dialysis units, you'll find quite a good number of patients having COVID positivity. Patients on regular dialysis should adhere to prescribed schedule and not miss the dialysis sessions to avoid any emergency dialysis. Another problem with this dialysis unit is that you just cannot enforce routine or regular testing, because primarily this is quite costly test, and secondly, this and also these patients need to visit hospitals sometimes twice or thrice a week. So it becomes practically quite difficult for them to routinely screen themselves as far as RT-PCR is concerned. There will be three situations of patients who require dialysis: patients already on maintenance dialysis, they need to continue with that, and patients requiring dialysis due to acute kidney injury, because COVID sometimes causes acute kidney injury and they need dialysis support, and patients critically ill requiring continuous renal replacement therapy, CRRT. So this is another, this may be another outcome from a critically ill COVID patient. They may be dependent on CRRT. So these are the three situations mostly we deal with while dealing with COVID patients in the hospital. So coming to the universal source control measures, patients and visitors should ideally wear one mask. So that's very, very important. Cloth mask is acceptable, but it's always better if medical mask is worn. If they're not having any mask, it should be offered. Now, whatever I'm speaking and whatever I will be speaking in this entire session, it will come from the recommendations and guidelines. So I'll highlight which one is international, which one is national, and which one is local or regional, in absence of proper international, regional, or national guidelines. And few of the gray areas I may highlight, but there is not clear-cut answer. But definitely there are certain best practices I may discuss, and if these things come up during this at the end during the discussion session, I can take up the questions. Now, healthcare personnel should wear a medical face mask at all times, including in break rooms or other spaces where they might encounter co-workers. I have intentionally highlighted this point because what we have observed during contact tracing is that most of the these exposures happen not only while handling a COVID patient. That time you're actually pretty conscious, pretty cautious, pretty careful. People tend to be fatigued. People tend to be casual after the duty hours. They tend to go to the canteen, have a cup of coffee with a fellow colleague, with the complete trust that fellow colleague is non-infected. So this is where we go wrong. So a face mask, medical face mask, must be worn even during break rooms and other spaces. And for the patients, certain norms are there which they should follow before arrival to dialysis unit. All units should instruct their patients to recognize early symptoms of COVID-19 and contact dialysis staff before coming to dialysis center. The unit needs to make necessary arrangement for their arrival in the screening area. So this recommendation is from interim recommendation from CDC. This has been updated very recently, less than a month back, I guess. So certain recommendations may look little fancy, maybe little difficult to manage in countries like India, but the purpose is to know the best. Then whatever you can customize as per your center is concerned, that you can do that. So primarily, patients are supposed to inform. You have to educate the patients on the signs and symptoms of COVID. Even a little breathing problem can be a marker for COVID infection. So you have to sensitize your patients, and accordingly, they are going to inform you preliminarily before their arrival so that you can be alert. Patients who are stable on maintenance hemodialysis may be encouraged to come to the unit alone without any attendance. So that's also very important. Usually, we do not advise to bring a number of attendants along with the patients. If the patient is stable, let him or her come alone. The screening area is a crucial area for dialysis, and this is often missed in many of the Indian hospitals. The dialysis unit should have a designated screening area. Where this is not possible, patients may wait away from the dialysis unit until they receive a specific instructions from the unit staff. And that area, even that area should be designated, because you never know how many COVID patients or asymptomatic or pre-symptomatic COVID patients are there among your dialysis patients. So that even that area should be designated and properly isolated to some extent. The screening area should have adequate space to implement physical distancing between patients and accompanying persons while waiting for dialysis staff. So physical distancing is a strictly essential thing even in the screening area. Patients with symptoms of a respiratory infection should put on a face mask before entering screening area and keep it on until they leave the dialysis unit. There are certain contraindications for offering face mask to a patient. If children less than 2 years, if somebody having respiratory difficulty, if somebody altered consciousness, or somebody having difficulty, somebody in communicating. Suppose that person feels uncomfortable, he is not able to take his mask off. So these are the situations where you should not offer a face mask to a patient. Other than that, largely you have to offer face mask for a patient. So for that, you have to also have a check on your supply chain management, whether you have sufficient stock of face masks to be offered to the patients. Patients with symptoms of respiratory infection should put on a face mask before entering screening area and keep it on until they leave the dialysis unit. There should be display of adequate information, education, and communication material like posters about COVID-19 in the screening area. So this is again a requirement as far as CDC is concerned, IEC material, and this is also adopted in ICMR. Inside the dialysis unit, suspected or positive COVID-19 patients should properly wear disposable 3-layer surgical masks throughout dialysis duration. So every word is important and self-explanatory. Patients should wash hands with soap and water for at least 20 seconds using proper method of hand washing. If soap and water are not readily available, then you can offer hand sanitizer containing 6% alcohol. So your job is not to train your health staff, but you have to train your dialysis patient, chronic dialysis patients on hand hygiene. Patients should follow cough etiquettes like coughing or sneezing using the inside of the elbow or using tissue paper. And you have to follow the proper waste management as far as these tissue papers are concerned. The trash where patients will throw these used tissues should be appropriately labeled, and the trash cans should be foot operated of adequate IC materials even in the dialysis area. Now, during dialysis, each dialysis chair or bed should have disposable tissues and waste disposal bins and appropriate hand sanitizer within the reach of patients and staff. And staff caring for suspected or proven cases should not look after other patients during the same shift. Again, I'm saying this is idealistic requirement, but I'm not sure how many of the Indian hospitals at this present juncture can offer 1:1 nursing in dialysis unit. But as far as possible, you have to try for that. Separating equipment like stethoscopes, thermometers, oxygen saturation probes, and blood pressure cuffs. This is the NIBP cuffs between patients to be cleaned with appropriate cleaning and disinfection materials, and even in between shifts. Even as far as the recommendation is concerned, you can use 1% hypochlorite solution for cleaning the Rexine material of that NIBP cuff. But largely, 60 to 70% alcohol is good enough for COVID-19. Well, the screening, triage, and maintenance and management of suspected or confirmed SARS-CoV-2 patients. So this is most important. So here, this is a kind of summary of what we should do, because this is quite extensive guideline. I'll just touch upon the salient features of that. You have to remind your healthcare provider not to report to work when they're ill. So for that, you have to, sensitize your healthcare providers. What are the signs and symptoms of COVID? And there should be a proper non-punitive HR policy. That, as far as their leaves are concerned, so they must not report to work if they're ill. Instruct the patients to call ahead to report close contact. If there is close contact within the last 14 days, the patients should be encouraged to inform the doctors or nurses or the healthcare providers in the dialysis unit. Post signs at entrances and at strategic places So you have to mention it's a little difficult for busy dialysis unit to go and educate each and every patient. So you can post certain signs. You can also post certain IEC materials like posters at different strategic places, so that it's during the dialysis it's little time consuming for the patients. So during the time, patients can actually self-educate themselves and provide patients, healthcare providers, and visitors with instructions in appropriate languages about screening and triage procedures. And the position supplies close to the dialysis chairs and nursing stations. But again, you have to it should follow the 5S. That means it should be properly sorted out. But supplies should be positions close to dialysis chairs and nursing stations. Placements of patients with suspected or confirmed SARS-CoV-2 infection. Well, during this time, you must have handled suspected and confirmed SARS-CoV-2 patients, but there is a recommendation how you should actually behave during this situation. Ideally, facilities should have areas for all patients to wait, separated by at least 6 feet. So that much of distance is ideal, otherwise as far as possible, but you have to ensure that physical distance is maintained. They should not sit in close proximity, and they should have the mask on. Patients with confirmed SARS-CoV-2 infection can be cohorted together. That means they can be put in the same waiting room. However, they should again maintain at least 6 feet of separation, even if they have confirmed SARS-CoV-2 infection, because the viral loads may be different, and you never know how in immunocompromised condition how different viral loads can behave in someone's body. Patients with suspected SARS-CoV-2 infection and patients who have had close contact with someone with SARS-CoV-2 infection should also maintain at least 6 feet of separation from each other and from other patients at all times in the dialysis facility. So if I sum up, then the 6 feet distance should always be maintained. If there is close contact, if there is exposure, if there is a proven case of SARS-CoV-2 infection. Well, I devote an entire slide on separation because that's very, very important and you must know this properly. Ideally, a patient with suspected or confirmed SARS-CoV-2 infection or who has reported close contact should be dialyzed in a separate room, if at all this is available, with the door closed. Again, I would say every word is important. The door has to be closed. Hepatitis B isolation rooms should only be used for this patient. See, what happens during this time, we see that a lot of hospitals, in absence of segregated area, they demarcate the hepatitis B isolation room or HIV isolation room to these COVID patients. Well, you can do that only if the patient, that means the COVID patient, is hepatitis B surface antigen positive, or the facility has no patients on the census with hepatitis B infection who would require treatment in the isolation. So if these two criteria are matched, then definitely you can offer this hepatitis B isolation room to the COVID patient. If a separate room is not available, the patient with suspected or confirmed SARS-CoV-2 infection or reported close contact should be treated at a corner or end of row station, away from the main flow of traffic. If, again, I would say if this is available, the patient should be separated by at least 6 feet in all directions. This is also important. It should be maintained from all directions. The next most suitable option is the use of separate shift, preferably the last of the day, usually the night shift, for dialyzing all such patients. So generally, in all practical purposes, we use the night shifts for all these kind of suspected or proven COVID patients. If a hemodialysis facility is dialyzing more than one patient with confirmed SARS-CoV-2 infection, consideration should be given to cohorting these patients and the healthcare provider caring for them together in the same section of the unit and or the same shift. Again, we would consider the last shift of the day. That best part is to have an isolation room. If that is not available, then you can cohort the patients, and finally, even if that's not possible, then you have to make use of the last shift of the day. But the intent of this slide was to make you aware that sometimes we allocate the hepatitis B isolation rooms for COVID patients. That should not be given, on a very casual note. This can be given only if the patient is also having hepatitis B surface antigen positive, or the facility has no Hep B patients in census. So the recommended PPE when caring for suspected or confirmed patients, the N95 or equivalent or higher level respirator, eye protection, gloves, isolation gowns. Eye protection is very important. Wherever I get a chance, I always emphasize that eye protection is very, very important for while dealing with any COVID patients, but this is largely missed in our day-to-day practice. This is again recommended PP when caring for suspected confirmed patients that wear eye protection medical face mask here and wear N90 for equivalent or higher level respirator. And staff using PP should be careful on certain things that they will not be able to use washroom. And after wearing face shield, moisture appears. So whatever machine preparation or some medication preparation can be done in the non-infect area, that should be done before donning that eye shield. If dialysis is to be done bedside in the hospital, portable RO should be properly disinfected with 1% sodium hypochlorite. Now coming to the cleaning and disinfection part, which also part and parcel of this dialysis room, that bed linen should be changed between shifts and used linen and gowns be placed in a dedicated container for waste before leaving the dialysis station. And disposable gowns should be discarded after use. Cloth gowns should be soaked in 1% hypochlorite solution for at least 20 minutes before sluicing and then transported for laundry. And inside the dialysis unit, clean and disinfect frequently touched surfaces at least thrice daily and after every shift. So that needs to be monitored and it should be countersigned by the in-charge there. It should not be completely left upon the housekeeping staffs. So there has to be some ownership of the nursing in-charge or the doctor in-charge. This includes bedside tables and lockers, dialysis machines, doorknobs, light switches, countertops, handles, door handles, desks, phones, keyboards, toilets, faucets, and sinks, etc. So these are very, very important. And stethoscope diaphragms, NIBF cuffs, and tubings should be cleaned with alcohol-based disinfectant. So this is a wonderful checklist given by CDC. This is freely downloadable, and this is for dialysis station routine disinfection. So whatever I said, this is there as a checklist. So this can be made use of in our day-to-day practice. Environmental surface disinfection. These are the notes for clinical managers, and select proper disinfectant and determine correct dilution for routine. So this is again very important. We should not unnecessarily use very high level disinfectants. SARS-CoV-2 is a very fragile organism, and just 60% alcohol is good enough to kill that. And we must not use unnecessarily strong disinfectants that may be corrosive, and the material safety can be and material compatibility should be ensured. Otherwise, in course of cleaning and disinfecting surfaces, we end up having corroded equipments which are very costly at times. Establish procedures for disinfecting dialysis station between patients. Ensure staff have been properly trained. I'll touch upon the training parts in my subsequent slide. Ensure the staff have access to proper supplies. So each and every point is important, and these come under the purview of clinical managers or managers, as a matter of fact. So staff should have a proper training, and this should be documented with post-training evaluation, ideally on standard precautions and hygiene. The dialysis unit staff should be trained for donning and doffing of PPE, also the disposal part of that. All staff should be trained for cough etiquette, hand hygiene, and proper use and disposal of masks, gown and eyeglasses, and the need to protect themselves. Well, this is a very important slide that responds to newly identified patients or healthcare provider with SARS-CoV-2 infection. So it's very easy when an individual presents with COVID-19 symptoms. It becomes a little difficult when the individual, infected individual, did not have any symptoms, and he can identify the date of exposure. If the date of exposure is identified, then usually 2 days after that, the period of infectivity starts. And if the date of exposure cannot be determined, then it becomes a difficult proposition altogether. Then the person, that means the main person, index case, his sample collection date is considered. So 2 days prior to that is taken as date of exposure. So this is, one of the difficult areas which is very beautifully addressed by CDC, but not properly addressed by other guidelines. So this is how you can, understand the date of exposure. And if the infected individual is a healthcare provider, so this is the risk assessment that you have to do, and accordingly you have to take care of the isolation or self-monitoring part. So I have two slides there. So the first slide is for when there is no source control. That means the patient is not wearing a face mask. Then it becomes really difficult, and high risk exposure is kind of unavoidable. So you come within 6 feet and stay for more than 15 minutes, and you become highly exposed. So then the exclusion from work 14 days after last exposure is a kind of mandatory. It comes down to medium when the healthcare provider wears eye protection. So still the verdict is same. But when the healthcare provider wears face mask and eye protection but does not wear gowns, gloves, then it falls under the category of low exposure, and self-monitoring is good enough for that. But when you offer mask to the patient, then the ballgame changes dramatically. So this is why we keep on saying that offer mask to the patient, because here you can see even if there is some fault from the healthcare provider part, still the maximum exposure is medium level. Okay, so and even if the healthcare provider forgets to wear eye protection, still it falls in the category of low risk exposure, and its delegated supervision is good enough for that. So you can, otherwise you have to be very, very careful. There has to be proper risk assessment. Otherwise, you're going to lose your healthcare providers because it's a kind of, huge exposure risk, and a big chunk can be, quarantined if they're exposed. And honestly, we cannot afford to do this in this crisis of manpower. If the infected individual is a patient, then definitely we all know how to deal with that. Patients were within 6 feet of the infected patient for a total of 15 minutes or more. That means I'm talking about a patient who got infection from the dialysis unit. Should be considered potentially exposed even if masks were worn, because generally dialysis patients wear cloth masks. In general, exposed patients should be dialyzed separated from other patients by at least 6 feet and cared for by HCP using all recommended PPEs. So this is why we always say that maintain a difference of 6 feet, because otherwise there is high chance that one dialysis patient can catch infection from another patient and will end up having COVID-19, which is primarily hospital acquired. So definitely the adverse outcomes will be there, and also the legal issues. The exposed patient was wearing a medical face mask instead of a mask, a risk assessment can be considered. So in case you offer a medical face mask to the patient, your life becomes a little easy, and definitely you can have some scope of risk assessment, and accordingly you can offer quarantine or self-delegation, etc. This slide is important because any transmission within a dialysis facility should be considered an outbreak. So the definition of outbreak is changed here. As far as CDC is concerned, in a single case, any transmission within the dialysis facility should be considered an outbreak. What we are supposed to follow, if a such outbreak is suspected, facilities should consider using PPE recommended for care of patients with suspected or confirmed infection for all patients. And you have to notify the local health authorities. And finally, if facilities experience large numbers of newly infected healthcare providers or patients over short periods of time, that means over 1 week, universal PPEs and or facility-wide testing might also be considered. So we have to give PPE to each and every patient, irrespective of their status, and you have to start testing facility-wise. And the final part that is not mentioned in the CDC, but sometimes mentioned in other regional guidelines, that you may have to close the unit. So dialysis with acute kidney injury, it is suggested that all modalities of RRT, that renal replacement therapy, may be used for patients with AKI depending on their clinical status. Patient admitted in other ward of the hospital with AKI should be preferably given bedside dialysis rather than shifting patient in main dialysis unit. In such situation, portable RO water in a tank will serve the purpose. So in best of the situation, buy a portable RO system and give it to the bedside of the patient instead of bringing the patient to the main dialysis unit. If more dialysis is expected in selected area, dialysis machine may be left in the same area for future dialysis. So you can allocate a portable RO system in the COVID ward or COVID ICU of the hospital. Ideally, this procedure should happen in COVID-19 dedicated hospital or ward. Discharge policy. There is no proper discharge policy in international national guidelines. So I have borrowed this discharge policy in our state guideline. So COVID positive patients with kidney disease who are discharged but yet to turn negative for COVID will continue to receive dialysis in the same dedicated COVID dialysis unit. That patient was admitted on daycare basis. Pre-designated slot may be provided. So this is very important and this is very difficult to follow. That means if the patient is still positive, you have to bring the patient in the same unit. You cannot bring the patient in your previous main dialysis unit. You have to bring the patient to the same dedicated COVID dialysis unit. Testing for COVID may be done every 7 days post-discharge or on every third consecutive dialysis session, whichever is later. They'll be referred back to the parent dialysis units once they turn COVID negative. So COVID testing is kind of essential for returning back to parent dialysis unit. So the IPC protocols in labor room. So this is the guidance on management of pregnant women. Obstetric unit should take into consideration the following parts: appropriate isolation of pregnant patients who have confirmed COVID-19 or are persons under investigations. We call it PUI. Basic and refresher training for all healthcare personnel to include correct adherence to infection control practices, PPUs, and handling. It's advisable you provide a video presentation instead of didactic monotonous lectures. Sufficient and appropriate PPE supplies, positions at all points of care, and processes to protect newborn from risk of COVID-19. Well, this is the ICMR specimen referral form that we are referring to for sample collection. So here you can see the category 7, pregnant woman in or near labor. You are justified to go for testing. So if you can test, then your life becomes easy, and you can take all sorts of precautions, but it may be a little tricky when a patient, when a expectant mother arrives without having a testing report and in absolute emergency condition. So there you do not have the time to go for testing, and there you have to take all necessary precautions. So considering the mother as COVID positive, so we'll follow the same old dictum that we used to follow for HIV and other infectious diseases, that unless proved otherwise, treat everybody is having kind of infections, bloodborne viral diseases. The same dictum partly applies to pregnant women if they present with tested report. So this is again a CDC guideline, but this was adopted in ICMR. So I'll just explain in a very simplistic way. If the patient is asymptomatic, then definitely you can go for SARS-CoV testing, because this reflects in our ICMR protocol. If negative, then fine. If positive, then isolation at home for 14 days. If delivery is imminent, no breastfeeding, mother isolated from newborn until viral shedding clears. This no breastfeeding part has been changed in ICMR from the CDC part. Okay, so after WHO intervened on this breastfeeding part, likewise it was changed in ICMR. So now breastfeeding is allowed, taking all necessary precautions. And for the symptomatic patients, where monitoring at hospital is required, you keep the patients in negative pressure isolated room. We call it IRNP. You have to wear the protective gear for visitors and health personnel, and delivery neonatal procedure equipment should be placed on site. If SARS-CoV-2 is negative, then fine. Still, you have to continue isolation at home for 14 days. And if symptoms persist, you have to plan retest, because as you know, the sensitivity of RT-PCR, it's not 100%. Definitely, the more you perform, the more the chance of capturing the real status increases. And if the patient turns out to be SARS-CoV-2 positive, then you have to hospitalize in a tertiary care center, ideally, where everything should be checked. And this even if the patient is in critically ill condition, then delivery has to be considered. And after 24 weeks of gestation, vaginal delivery is recommended, and induction of labor plus minus instrumental delivery when possible, unless severe failure criteria. Early clamping of the umbilical cord, early cleaning of the newborn monitoring in isolated room, negative pressure. And you have to do SARS-CoV-2 RT-PCR for the newborn. No breastfeeding, but again, this has been changed by ICMR recently. And here something is very important, that as far as the protective gears are concerned, that contact and airborne additional measures are to be taken. So first time airborne additional measures feature in this part: FFP2 or N95 mask, gloves, gown, or eye protection. For antenatal care, whenever this is feasible, you have to postpone coming to hospital. We defer until 7 days if there is some symptoms. And for women who are self-quarantined because someone in the household had possible symptoms, that should be deferred for 14 days. Even if a woman has previously tested negative, still having symptoms now, they should be retested. For intrapartum care, assessment should be done by multidisciplinary team, where infectious disease or medical specialists should also give their comments, and delivery should preferably done at tertiary care center, that is dedicated delivery center for COVID. This is the PPE. Mostly this is same, only body protection, long sleeved, water resistant, complete gown, including head and shoe cover. A single piece head to toe water resistant body cover will be ideal for attending resuscitation in delivery room in OT. Apart from that, rest other protections are more or less same. Here in the labor, there is currently no evidence to favor one mode of birth over another, so there is no such recommendation. In case of deterioration of the woman's symptoms, individual assessment regarding the risk and benefits of continuing the labor versus emergency cesarean section needs to be made. And when cesarean birth or other operative procedures advised, it should be done after wearing PPE. And individualized decision should be made regarding shortening the length of second stage of labor. So this is something important, purely technical. So I'm not going to that, for whether to go for elective instrumental part in a symptomatic woman who is becoming exhausted or hypoxic. This is, for temporary separation part, whether we should separate the mother from the baby. What the guidelines say, this is captured from ICMR, because I found it quite relevant to our countries, because this is directly our country guideline. The risk and benefits should be assessed and discussed with the patient. So this discussion part should be there, and should be documented. Separate isolation room should be available for the infant while they remain under investigation. The decision to discontinue temporary separation of the mother from her baby should be made on a case-to-case basis in consultation with the clinicians, infection prevention and control specialists, and public health officials. Decision should be taken into account disease severity, illness signs and symptoms, and results of laboratory testing for virus that causes SARS-CoV-2 of mother and newborn. So it should be individualized decision, and has to be, it's a dynamic situation that this must happen among this multidisciplinary team. If collocation, that means the rooming in has to happen, then this, or if it is unavoidable due to facility limitations, there has to be some measures which should be implemented to reduce exposure of the newborn to the virus that caused COVID-19 in his or her mother. Consider using engineering controls like physical barriers. A simple curtain is good enough, and you have to keep the newborn more than 6 feet away from the ill mother. If no other healthy adult is present in the room to care for the newborn, a mother who has confirmed COVID-19 or under investigation should put on a face mask and practice hand hygiene before each feeding or other close contact with her newborn. So this is essential for us, because mostly we are having this kind of situation in countries like India. We are not always blessed with proper isolation rooms. The face mask should remain in place during contact with the newborn. These practices should continue while the mother is on transmission-based precautions in a healthcare facility. Coming to breastfeeding during temporary separation, mothers who intend to breastfeed should be encouraged to express their breast milk to establish and maintain milk supply. EBM, expressed breast milk, is preferred. If possible, a dedicated breast pump should be provided prior to expressing breast milk. Mothers should practice hand hygiene after each pumping session. All parts that come into contact with breast milk should be thoroughly washed, and the entire pump should be appropriately disinfected as per the manufacturer's instructions. EBM should be fed to the newborn by healthy caregiver. Again, that is also important. The caregiver must be healthy. The mother and the newborn do room in and other mother wishes, and the mother wishes to feed at the breast, she should put on a face mask and practice hand hygiene before each feeding. For hospital discharge, the test must be negative, and that's also important. Is our ICMR criteria that the mother or the baby should test negative before discharge. So coming to the gastroscopy or bronchoscopy room, for the pre-procedure screening is very, very essential for this. Unfortunately, there is no fixed guidance for India, only that you can make use of the others section in the ICMR SRF ID form. That means before any surgery or procedure, you can do a COVID testing. So you are legally allowed for that. So in that case, you got a negative report. And but when you can do this, if you plan to do this on the date of procedure, then it becomes a very, very difficult situation for the patient practically, because he has to come in the morning in empty stomach, get himself or herself tested, wait for the entire day, and by evening his numbers comes, if at all he or she tests negative. So it becomes very difficult. So when we can do this COVID testing, if it is allowed, so this ASGE, that is this American guideline. So this is quite clear on that testing either the presence of convalescence antibodies to SARS-CoV-2 or a negative molecular test within 48 hours. So your test, if it is done within the last 48 hours, is still valid for a daycare procedure. So that's important. I kept this slide only to show that there is some reference for this 48 hours. This is not just just kind of practice we have started. So there is a definite reference for that. In the procedure room, there has to be minimum staff and appropriate PPE. Disinfection should take place, and negative pressure isolation room. Negative pressure room, if this is available, then it's best. This is how you actually risk assess the patient, and accordingly, based on their risk, you wear your PPE. But your life becomes easy once you have your test reports at hand. But again, I suggest that in this pandemic situation, even if you have a negative RT-PCR at hand, better to take every patient as COVID positive and to adopt highest level of personal protective equipment whenever this is possible. Now, this is a very interesting study that I have come across, that endoscopy procedure room droplet areas. So they have said that head is actually the source of creating all droplet areas. So it's a 35 centimeter arc which is actually created. So based on this figure, you can position your patient, and the main idea of this study is that to stay away from these arcs. If you stay away from this droplet generation field, then the less you expose yourself during the course of procedure. So the positioning of the patient's head on the bed, that's important, and you have to know the droplet safety distance. So once you are very clear on that, you can actually take care of yourself. In addition to wearing appropriate PPEs. Post-procedure observation, adequate spacing between beds, at least 6 feet, should be ensured. Surgical mask should be provided to patients. So this is again very important. This is surgical mask. No cloth mask is mentioned over here. Next, it's infection prevention control protocols and catheterization laboratory. So mostly patient selection is important. If you have the time, you can make use of this ICMR recommendation and go for COVID testing and admit a patient once they are COVID negative. But if you're unlucky, the patient presents in emergency condition and you do not have time to go for testing, then definitely you have to take all necessary precautions, and you have to consider all patients as COVID positive unless proved otherwise. and you have to protect the healthcare workers with appropriate PPEs. There are certain considerations specifically pertaining to cath labs. Only essential staff or personnel to be allowed access into the catheter laboratory. No extra staff is allowed. Clinical discussions between medical staff should be performed via phone as far as practicable, and physical distancing to be adhered to by everyone. Limit the amount of contact between groups of staff if possible. That is, nursing medical teams to be segregated, but it's difficult in practice. So this is not my words, difficult in practice. I have actually copied and pasted from international guidelines. This is a consensus guidelines. So they have also mentioned that it is difficult in practice. So we have to realize this is really difficult. And limit the amount of different staff that have contact with each individual patient. Limit wait times for patients in catheter laboratory corridors. So this actually we can improve upon. If you look into your hospital, you will see that there's a long waiting time for patients in the cath lab corridor. This can be reduced drastically if you are actually proactive. Accept patients only when the cath lab is ready and the team has done PPE. So these last 2 points, I think these are absolutely doable, and we can reduce our chance of exposure to a great extent if we make a very smooth and quick transfer and transfer wheeling in. The IPC protocols in CSSD, I think there's a separate session on CSSD. Only I'll do the basic parts on CSSD, that is filtering face piece respirators. This is the most important thing that we are talking a lot. There's a lot of controversy whether we can reuse the N95 masks, right? So primarily there has to be need assessment. You have to evaluate the adequacy of your current inventory and supply chain. If you do not have any inadequacy, if you do not have any short supply, then fine, you just go ahead with your existing practice. Forget about reusing. But considering this pandemic to stay and the costly expense of this N95 FFRs, you may have to think this proposition of reusing. Evaluate availability of other respirators in your inventory, and you have to evaluate extended use of N95 mask. We are all doing extended use. What do you mean by extended use? That means you wear the same N95 mask, and during the entire shift you see all the patients. So this is very frequently done in our centers, and it's quite acceptable. For this FFR decontamination part, decontamination is a process to reduce the number of pathogens on used FFRs before reusing them. So you must understand that you are actually not sterilizing, you are actually decontaminating. It is used to limit the risk of self-contamination. Decontamination and subsequent reuse of FFRs should only be practiced where FFR shortages exist. Decontamination should only be performed on certified FFRs without exhalation valves. Again, this is a very important point, that this is only allowed on certified FFRs where you do not have any exhalation valves. Decontamination might cause poorer fit, reduce filtration efficiency, and reduce breathability. Decontamination may produce chemical inhalation risk and should be evaluated for off-gassing. And effectiveness should be evaluated. Effectiveness is a little subjective, whether this based on fit, filtration performance, contamination, soiling, and damage. So these are the reuse determinants, and these are the methods, accepted methods by CDC: ultraviolet germicidal irradiation, vaporous hydrogen peroxide, and moist heat. So largely, most of the Indian hospitals have taken recourse to this vaporous hydrogen peroxide and moist heat. So these are moist heat, especially, is a quite cheap method, and you can actually reuse it for quite a number of times. But number of times, now how to assign that maximum number of times. So as far as this vaporous hydrogen peroxide is concerned, so maximum number of times is 3 as per the advanced sterilization protocol. Now the selection criteria for N95 respirator: the N95 must be used by all healthcare workers mentioned in the collection points for caring patients other than confirmed COVID-19. So for those who are dealing with confirmed COVID-19, their masks are not to be reused. Please make it very, very clear. So this is not for reuse, is not for confirmed COVID patient handlers. Discard the mask used while performing aerosol generating procedures, those which has lost the impurity and those contaminated with blood and body fluids are damaged. So what are the aerosol generating procedures? Like somebody is on BiPAP, on nebulization, you're giving suction. So these are the areas where a lot of aerosols are generated, and you're not supposed to reuse those N95 masks. So you have to be very clear on that. The respiratory integrity of mask must be tested by seal check test and also strap elasticity test by the wearer before use. This is Indian guideline. I have purposefully avoided certain CDC guidance here because those things are not very easily available in countries like India. So our Indian standard is there can be tested by seal check test and strap elasticity test. So these two are the markers, practical markers. If found not fitting well, must be discarded by the wearer. So there is no compromise on these two issues. So reuse policy for goggles, where also case is the pitch in that immerse the goggles in buckets of freshly prepared 1% sodium hypochlorite for 10 minutes. And the hypochlorite should not be more than 4 hours old. Wash it thoroughly in water after immersing in water for some time. Allow it to dry in sterile area. And only after the surface is completely dry, wipe all surfaces with 70% alcohol using a clean pad and store it in clean dry containers or plastic covers. So I'll stop over here. I think I have overshot my time marginally. So these are my references. WHO, CDC, Ministry of Health and Family Welfare, ICMR, and Society of Gastrointestinal Endoscopy of India, Indian Society of Gastroenterology, and Indian National Association of the Study of the Liver, American Society of Gastrointestinal Endoscopy, and American College of Cardiology. So thank you so much for the kind attention. So I'll just end with this quote: the challenges are what makes life interesting, and overcoming them is what makes life meaningful. So I believe this presentation will help you in tackling our day-to-day crisis and confusions in a more confident way, and we can do justice to the patients who are heavily dependent on us and also take care of our own staff. Thank you so much for the kind attention. I'm ready to take up any question.
Okay.
Okay.
Thank you, sir, for that wonderful session. I think it was highly informative, highly interactive, and very, very knowledgeable. I think you've given us what is the latest updates in the guidelines, both nationally and internationally available. And I think you've put it in a way that a lot of people can understand and try to follow. Just before we take up a few questions, just a few thoughts from my side, just few observations from my side. As you said, you talked about a medical mask. Just to update that, currently Ministry of Health and Family Welfare gives certain recommendations on medical mask. It should be a 3-layer mask, and it's actually the correct terminology. What we should say, it should be a surgical mask, which is a 3-layer filtration mask. So this should be advised for all patient caregivers, and definitely to all our healthcare, the patients and patient attenders also. And definitely, as you said, N95 mask should be there. Another process that, as you said, one should not use hypochlorite unnecessarily, because hypochlorite is quite toxic and corrosive. Most of it can be done with 70% alcohol or higher concentration wipes that are there. If so, one of the suggestions that we would like to do to people over here is, rather than using liquid hypochlorite, have tablets, hypochlorites available in tablets, and mix it and use it as and when it's required. So that is one thing. And last but not the least, when cleaning instruments, this is again, as you mentioned, about cleaning COVID-19 positive cases or non-COVID-19 positive cases. Two things have to be kept in mind: that instruments have to be first always cleaned with an enzymatic cleaner, preferably with a multi-enzymatic cleaner, which is always better, which has a kill ratio of both bacteria and viruses. Plus, we should also then dry it. Then only we should put it for disinfection and sterilization. So cleaning is the first and most important step that is there. And for people who were asking about the N95 decontamination, just I have put it in the chat box also. The website is called as www.n95decon.org. So there they can go and find some more guidelines on reuse and decontamination of N95 mask. So that's about it. A few comments from my side.
Thank you for this really important inputs, and really.
So we will take a few questions here, sir. Bridget from Fortis asks that how would you like to do the terminal cleaning of a dialysis unit after a COVID positive patient has been treated, sir? What would be the steps for terminal cleaning?
This is a general terminal cleaning. But here, I mean, whatever surface cleaning agents you're using, they are pretty well applicable for this.
Okay.
And the only thing I would like to state over here, that we must not be over dependent on fumigation.
Okay.
Because again,
That's what I wanted to know.
yeah, I got this opportunity to talk about this actually, because we see a lot of hospitals are overusing and overdoing this fumigation, and a lot of companies are unnecessarily promoting fumigations that they are not much required, whereas we are forgetting that high touch cleaning, high touch surfaces or disinfecting high touch surfaces more than enough.
Absolutely.
So whatever hospital approved disinfectants you have, sir, in your hospital, this may be quad, this may be something else, just use it and clean your high touch surfaces, scrub it, the walls and the surfaces, and that's good enough.
Yes. Thank you. So I think that was one very important highlighting point, that people are doing over fumigation, and fumigation has to be only kept in mind that whenever we are doing any gas gangrene cases or where the spores are spreading in the air, then we need to use fumigation.
Okay.
Yes. Then the next question is that how reliable is the antigen test before surgery, or is RT-PCR required?
No, it's a very good question. I must appreciate the person who raised this question. So here we have to understand why you're doing the test. So primarily antigen testing should be done where you have a high test probability. Okay, so high index of suspicion. So definitely for a person who is posted for elective surgery, you do not have high index of suspicion. So there, antigen testing is not going to be very, very valuable. You're going to miss out a lot of cases. We recommend antigen testing mostly for persons who are having signs and symptoms of COVID or present with SARI symptoms. So if a person is not having any SARI symptom, completely asymptomatic, so their RT-PCR is definitely the test which we should depend upon, not the antigen test.
Okay. So hopefully that answers the question. So this last question is a little bit tricky. I will probably also join you to answer this. The question says is, what is the percentage of hydrogen peroxide that is recommended for vapor?
I think you join in here.
Okay, fine. So I would just like to answer the question. There are two types of hydrogen peroxide sterilizers that are available. One is commonly called as the vapor-based this thing, and the other thing is called as the what we call as the gas plasma-based system. Yeah. So each one has a different concentration of hydrogen peroxide which is used. When it comes to vapor hydrogen peroxide, the concentration is between about 40 to 60%, while for the glass plasma, they use about 80 to 85% concentration of hydrogen peroxide. So each one is US FDA certified to be used as a sterilizer. And currently, if you look at the website that I mentioned, N95 Decon, the preferred method is vaporizing hydrogen peroxide. You can also use ultraviolet rays, but only thing to keep in mind whenever you're using ultraviolet rays, the strength of UVC rays has to be checked and confirmed before we use a UV box. So that is what is this thing. So hopefully
very precisely answered. Yeah, at this juncture, I would also like to say that HICPAC, as far as this fumigation recommendation is concerned, HICPAC recommends only using hydrogen peroxide for Acinetobacter or this kind of outbreaks. That's the only recommendation you find from developed countries and from best of the guidelines.
Okay, sir. Last question before we close the session. What about the status of using reuse of single-use devices in the Cath Lab in COVID-19 situation? Do you still recommend it?
Yeah, this is recommended. Although the only good part about COVID is that it's a very fragile organism, as I have said. So you can just follow your previous practices. So whatever you have been following, this reuse of single-use devices, that all these existing norms, that should be very stringently followed. If you follow that, then it's fine. And whenever you're dealing with a suspected COVID patients, our general tendency is to keep the patients at the fag end of the procedure list, so that can be continued.
Absolutely. So just to add to that, as we said, continue your regular protocol. Use an enzymatic cleaner, clean it, dry it, flush it, then complete it. After that, you can use hydrogen peroxide, then sterilize it in ETO. That should absolutely take care of all kind of viruses and spores also. Okay. Just to add to the question, are there any guidelines specifically for single-use devices in COVID?
No, I do not have.
Okay. So currently, as we said, meant to Dr. Deepthi who asked this question. So, ma'am, there are no specific guidelines, as we say. You can follow the American Society of Cardiology guidelines, but they don't recommend reuse of single-use devices. So it is better we follow the Indian guidelines, because currently NABH and Indian guidelines say that you can reuse single-use devices. Only thing, follow your strict decontamination, disinfection, and sterilization protocol. Yeah, so that's about it. We will close the session at this point of time. I would like to thank Dr. Dev Kishore from all our sides, from Resh's side, from Schulke's side. Thank you so much.
Thank you. It was a nice session. I also enjoyed a lot.
Okay, so just an information before we sign off, request everyone to fill in the feedback form in the email that is there. And we would also request all of you to join our next webinar, which is on the ICU and management of COVID patients in ICU, which is on December 5th, which will be around the same time at 3 p.m. itself. And with that, thank you, Dr. Dev. Wonderful session.
Thank you.
Thank you again.
Thank you so much.
Thank you all for the participants. Thanks all the participants. Bye-bye. Good day.
Bye-bye.
Thank you.